Good morning, y'all. Happy Tuesday. I'm a little later than usual on here, but today's live, I was asked the question, what is the typical day of a CRNA like? And I'm going to do this video today, and then tomorrow I'm going to do what was the typical day of an SRNA like. It's a common question that I've been asked, and because I've been doing it so long, I just kind of like don't even think about it. Good morning. Yay. Tonight's our last night of class. Can you believe it? I'm sad. I'm going to miss y'all. Good morning, cousin. Good morning. Good morning. I hope y'all have a great Tuesday. It's cold outside this morning. So I took the dogs out and came right back inside, but I wanted to talk about a typical day as a CRNA. I get asked this question a lot. So let's see. My days usually start very early as a CRNA because I do work night shift. There are lots of different shift options as a CRNA that you can work. There are 8-hour shifts, there are 10-hour shifts, there are 12-hour shifts, there's 16s, 24s, there's 4-hour blocks, like if you go in to help with lunch breaks and things like that. Oh, thank you. So typically I do 8-hour shifts now at this point in my career, or 4-hour shifts, because I am per diem now. I do not work full-time anymore, because I am primarily focused on my business ventures and coaching others who either want to be a CRNA or want to be a nurse or just want to get to their next level. So that is what my coaching is for. And then I have Superscript Wellness, which is my gummy line, my vitamin line. So if I go into work, it's strictly just to help out for a few hours. So I usually get up about 4:30 in the morning, and I meditate, and I drink 32 ounces of water, and then I take the dogs out, let them do their business. I feed them. I work out for 30 minutes a day. I do my workouts first thing in the morning. I cannot wait to the end of the day, because if I wait to the end of the day, I'll be too tired. I used to wait until the end of the day at one of my other CRNA jobs. That job was probably the easiest job I've ever had as a CRNA, so I had the energy. The current facility that I do go and help out at every now and then, you're not gonna have the energy. I didn't have the energy, so I work out in the morning, shower, and then I bring the dogs to the dog sitter. If I'm going to do an 8-hour shift, bring the dogs to the dog sitter for 6. I arrive to the hospital anywhere between like 6:15, 6:20. Oh, thank you. I love you. I arrive to the hospital 6:15, 6:20-ish, and then change into scrubs. So we wear sterile scrubs in the operating room, so the scrubs are there for us already. Change into scrubs, put my lunch away, and then I go to the operating room. Whichever assignment, we usually find out the night before what our assignment is, and so we can mentally prepare. So let's say I'm going to be doing cystoscopies. Cystoscopies are when they go and they look in patients' bladders, or their kidneys, like if they have a kidney stone and they either take the kidney stone out, or sometimes they put in stents. They do all different types of things. So let's say I'm doing 7 of those in my room, right? So I get my room ready by turning on the anesthesia machine and doing a safety check on my anesthesia machine. There's tons of different anesthesia machines. Every facility has a different anesthesia machine. No anesthesia machine is the same, although I have found that the newer ones are kind of becoming similar. But there's things like Drager's, there's Datex Omedas, there's Narcomeds, there's, I know I'm forgetting one, but most of them do a self-checkout now, so you just have to kind of go through the steps. The machine will tell you which steps to go through, and you type in what you want it to do, and it'll do it. There are some older machines where you physically have to like go through those steps, each step on your own. When I was in CRNA school in Jersey in 2010, 2011, 2012, I never worked, I won't say never, but it wasn't maybe until my senior year that I had a machine that did its own check. So I had to do all my checks on my own, and they walk you through that, like in CRNA school, like during simulation lab, before you even start clinical, they show you how to do an anesthesia machine check. It's actually one of your check-offs. So I go and sorry y'all, piece of hair on my lip gloss. So I go and I do my anesthesia machine check. While the machine, if it's one of the machines that does its own check, while it's doing that, I'll start drawing up my medications. Typically, if I have 7 patients, I draw up only for 1 patient at a time, if you get what I'm saying. So I draw up meds for my first patient, and I label all of my meds, time, date, initials. Don't forget that. It's the same when you're a nurse on the floor. So time, date, initial, all my meds. And then I look at my patient in the computer and their history. I could have done it the night before, but when I'm home, I'm home. Like when I'm home, I'm not on work time. So I look up my patients, their comorbidities, if I may need to change anything. By then, the physician anesthesiologist may have texted me and say, hey, Crystal, like this first patient has blah, 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 blah. You know, let's make sure we don't use Versed. Like, you know, let's say they're really old and fragile, elderly and fragile, and, you know, let's not give them Versed. So I won't give them Versed. It's a collaborative thing. It's not the physician anesthesiologist telling me what to do. It's them. They've already seen the patient in pre-op. They go and see the patients for us. And so that's us communicating. And so, or they may say, like if it's a really big case, they may say like, we need an A-line, or, you know, we're going to need 2 IVs. So I know that in the room, I need to have those things set up because that's what we're going to be doing. Okay. So, but we're doing easy cystos in this scenario, right? Oh, I won't say easy cystos, but we're doing bread and butter cystos. Bread and butter means easy. So if you ever heard that terminology, bread and butter cases, it means like your typical gallbladders, your typical appendix is coming out, your cystoscopies, your podiatry cases, like that's bread and butter. Although every anesthetic has a potential to be not bread and butter, that is a term that is thrown out. When you start hearing words like, you know, high call and cardiac cases and neuro cases, that's not bread and butter. When you're looking at jobs, that's not bread and butter. You're going to work. You're going to like need A lines and central lines, and you're going to be flipping patients. And so my job, I do some bread and butter and I do some bigger cases if I go to the main hospital. But I like bread and butter. Bread and butter, get me in, let me do my cases, let me go home. So the room is set up, the anesthesia machine is checked. We've only drawn up for our 1 patient. And then we go out to pre-op. Usually I run to the bathroom because once you're in the OR, you're in there. Like, you're in there until somebody comes and gives you a break. Or if it's like a dire emergency and you're like, oh my gosh, I have to go to the bathroom. No. Then you can page anybody. You can just say like any available anesthesia personnel, please come because I gotta go. Right? That is in this type of setting. There's some settings where you are the only anesthesia provider. So you either don't eat something that you know is going to have you go into the bathroom, or you don't drink, or I've heard horror stories about things that have happened because there's nobody to give the anesthetist a break, potty break. So anyway, I'm digressing. Okay, so I would run to the bathroom, or I'd take another swig of water, and then I'd go out to pre-op to see my patient. In pre-op, there's usually like a list on the wall, and you look and you find out which bay your patient is in, and or the computer system, like it'll be up on the board somewhere, and you go and you meet your patient. That's when you introduce your patient as a SRNA. You would say, you know, hi, my name is Crystal. I am the SRNA, or the nurse anesthesia resident for the day. I'm going to be working with Crystal as a CRNA. You know, blah, 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 blah. You'll learn how to talk to patients. It's different when you're coming from the ICU. What's up, Sean? It's different when you're coming from the ICU because you don't usually talk to your patients, because your patients are intubated and sedated. So anesthesia, you have a very quick amount of time to build rapport with your patients. So, hey, I'm Crystal. I'm going to be taking great care of you today. I'm going to be working with Dr. So-and-so. We're going to make sure we get you nice and comfortable for this before you go off to sleep. I'm going to give you a little relaxing medicine. And then, you know, I'll be there with you the entire time. I'll be watching your vital signs. And if something, you know, comes up, I'll be there. And when surgery is all done, I'll wake you up and you'll be in recovery and nice and comfortable. I'm going to give you something for pain. I'm going to give you something for nausea. And you're going to do great. So, boom, right? So, oh, you're welcome. I do lives every morning. I don't know if Instagram's been telling y'all, but there's a ton of lives on my page. I've been saving them, and on my YouTube. I put them on my YouTube as well. So make sure y'all are following me on YouTube. Like, subscribe, follow, whatever the wording is. But anyway, so you go, you introduce yourself to your patient. You tell them what's going to be going on. If they have any concerns, most of the time they already know who you are, because the physician anesthesiologist has said, like, hey, you know, I'm Dr. So-and-so. I'm going to be, Crystal and I are going to be working together. You'll meet her in a little while, because remember, I'm in the operating room setting up, right? So, you know, by the time I go to meet the patient, they're like, oh, you must be Crystal. And so, you know, you introduce yourself, you build that rapport very quickly, answer any questions they may have. They may have forgotten to say, like, oh, a lot of times they have to go to the bathroom at that time. You can either help them go to the bathroom, or you can find the pre-op nurse and say, you know, they need to go to the bathroom. If they've had a block of some sort or had pre-medication, they cannot get up and go to the bathroom. You need to get them a bedpan, tell the nurse to get them a bedpan, the pre-op nurse to get them a bedpan, and do not get that patient up if they've had pre-op meds, okay? So usually, you know, the one or two family members is also there, and, you know, you put the family at ease. Hey, I'm going to take great care of your mom, your sister, your daughter, whoever this is. I always ask, who's this here with you? I've made the mistake one time and said, I said, what did I say? Oh, is this your mom? Or something mom. It was not the patient's mom. It was his wife. So I never said, I never did that again. Okay, so don't do that. Okay, you always ask, oh, who's this here with you? And usually they're like, oh, this is my wife, this is my mom. Like, they look at you like, duh, but don't assume anything. Who's this here with you? Who do you have with you here today? Okay? Yes. Oh my gosh. Right. Okay. So, that's why I do these things for y'all, to give you little tips and pointers, okay? So, I'll never forget that, boy. Gosh, the patient started laughing. The wife did not. She was not happy. Sorry, ma'am. Oh God. Okay, so don't do that. Yes, they really, I'd rather have them be like, duh, this is my wife, than me saying something and it's the wrong one. Whew, Lord. Okay. So who's this here with you? Let's see what else. So then usually it probably wasn't the first time she had heard that. Usually, at the current facility that I work at, the nurses have the circulatory nurse has to come out with you to do the introduction. And so, then we'll do a timeout. We make sure there's the right patient here for the right surgery. So we want to make sure that the patient's consents have all been signed, the anesthesia permits have been signed. That is not something that I take care of. That's either the pre-op nurse's responsibility or the physician anesthesiologist's responsibility. I have at other facilities, gone and done anesthesia consent, and as an SRNA, doing pre-ops the night before, we used to have to go and get anesthesia consent and stuff like that. But at this facility, we do not. So we just are verifying the signatures are there, right? And that the patient knows what's going on. This is so important. Y'all have probably seen in the news things like, patient's wrong arm cut off for surgery, or wrong leg, or patient got the wrong, I was going to say, no, that's not right. So, wrong leg, wrong arm, something wrong was cut off. Okay. That is when you say to yourself, well, didn't they do like a timeout? Because you do several timeouts. You do a timeout when you first meet the patient. You make sure, they're the right one. They're having the correct, let's say it's eye surgery. I used to do a lot of eye cases. Which eye are we working on, right or left? And so they need to verbalize that, okay? The surgeon should have marked the area. So, they'll usually initial it. Like if it's an eye case, they'll initial up here. If it's an arm, they'll initial on the arm. If it's something like a cystoscopy, obviously they cannot initial your internal, area. So they'll usually have a bracelet on. So if we're going, right cysto, then they'll have a bracelet on the right arm. The camera is flipped. If they're having a left cysto, they'll have a bracelet on the left arm, or the surgeon may mark. Okay, so we have to see that mark. Then, if it's a young, healthy patient, then I'm going to give them some relaxing medicine. I don't like to say happy juice. Some people say happy juice. I say, I'm going to start you off with a cocktail. If they have a history of ETOH, I'm not going to say that, but I'm going to give you something to relax. Don't worry. I'm doing the driving. You don't have to worry about it. We're going to take great care of you. Boom. Let's go to the OR. So you will learn how to drive a stretcher as a CRNA. Every place I've worked, I've had to control the stretcher. So you will learn how to do that. It's not as hard as you think it is. You just have to know when to have it on steer, when to have it in neutral, and of course always put the brake on when you get to where you're going. Okay, always verify that the brake is on. Several people should be verifying that the brake is on, because the last thing we want is for a patient to go to move over to the operating room table and boom. Okay, we don't want that. So brake's on. So we drive to the operating room on a stretcher. I usually steer it. I tell the pre-op nurse, go in front of me, control traffic. I've got this. So going to the operating room, we get into the operating room. At the current facility, we have to be in the operating room no later than, I think, 7:15. So it's an early morning start. This is the earliest I've ever started at a job. 7:15 at my old job, I was sitting down to eat breakfast. Not this job. We're in the operating room. So in the OR, by then, I bring the stretcher up to the bed, put the brake on, lock it. We then do a second timeout. We have the patient then tell the surgical tech and the if there's another circulating nurse in there, who they are, what they're having done. They've had Versed by now, so most patients are going to say they do not remember from this moment on. They're not even going to remember going into the room, because Versed has amnestic properties. So we're going to have the patient say their name, what they're having done, and then we're going to say, okay, time to move over to the bed. If it's an elderly, fragile patient or, really sick patient, obviously we're going to call for assistance and we're going to physically move them to the bed. But if it's a young, healthy patient, over to the bed you go. From there, I am now at the head of the bed. I am letting the rest of the OR staff, do their thing, get the patient kind of centered on the bed and stuff. I am now at my Pyxis. I'm getting ready for my drugs, and I'm grabbing my equipment. Okay, I'm putting all my equipment on the patient from the head of the bed. That is something you will also learn as a SRNA, because it is not like when you're facing a patient in the ICU and you're putting leads on. You're at the head of the bed, so it's backwards and you're on top of them. So it's going to take a little maneuvering. You'll get it. Don't worry. So you're going to put all their monitors on. You're going to reassure them, you're safe. We're going to take great care of you. Usually, for the most part, patients are nice and relaxed by then because they've had the happy juice. Some may feel a little bit anxious depending on what they're having done, or depending on their history and stuff. And that's your job, to kind of reassure them. At that point, I'm going to text the doc, the physician anesthesiologist, or have the circulating nurse call overhead and say, we're ready for induction. Depending on where you work, I would go ahead and start. Depending on where you work and depending on the patient. If it's a patient that is sick, I'm waiting for a second pair of hands, whether it's another CRNA or a physician anesthesiologist. If it is a patient who's young and healthy and I feel extremely confident that I can get the tube in, no problem, don't need a second pair of hands, I'm going to go for it. So I'm going to start pre-oxygenating them, denitrogenating them, goodness gracious, and by giving them some oxygen. Okay, so the oxygen mask is going to go on their face. I'm going to have them take some big, deep breaths, and usually at this point, patients, they do not remember any of this, okay? And then they're going to go off to sleep. I'm going to give my concoction of whatever I've drawn up. Maybe it's Lido, propofol, and a little bit of fentanyl. And then I am going to put the advanced airway in. So if it's I don't know what that was. If it's a cysto, like we had started with in the beginning of this scenario, it's probably just going to be a LMA, a laryngeal mask airway. All right. Yeah, that's right. LMA. That sits above the vocal cords. It does not go down through the vocal cords. You do not need muscle paralysis for that. If a patient is extremely obese and has GERD and acid reflux, is aka GERD, or is going to be in an awkward position like prone, or I'll just say prone, we would not use a LMA. But this patient's going to be on their back. They're going to be in lithotomy, and they're young and healthy in this scenario, so LMA it is. I'm going to put the LMA in. I'm going to attach it to my circuit with the anesthesia machine. I'm going to turn on my anesthesia gas. I'm going to turn down my flows because my flows were high. If you don't understand what I'm saying, that's okay. It's okay. You're not in CRNA school yet. Or maybe you are and you haven't started clinical, but if you don't understand what I'm saying, that's okay. You can come back to this video when you are in CRNA school and you're like, I know what she's talking about now. Turn down my flows, turn on my my machine, and secure my airway, and tell the circulator she can prep, or the surge tech they can prep. And so now at this point, the patient is asleep. Their eyes are taped. They're relaxed. They're asleep. They have their advanced airway in. The anesthesia machine is breathing for them. If it's a quick cysto, I'm going to work on getting them breathing back on their own as quickly as possible. And there are maneuvers and things like that you would learn in anesthesia school, or even as a brand new CRNA, you're going to get your different techniques down, okay? So even when you graduate from CRNA school, you're still going to be fine-tuning your skills, okay? You're still going to be learning new stuff. I still learn new stuff as a CRNA of 8.5 years. So don't ever think you're not going to learn something new. SRNAs have taught me things because they're with so many different other CRNAs. They come into my room to work with me, and they teach me something new. I'm like, oh, that's a cool trick. And they're like, oh yeah, so-and-so taught it to me. So by then the patient is ready to go. The surgeon's gonna come in. We're gonna all stop. The whole room is gonna stop. Nobody should be moving. Nobody should be talking. Nobody should be doing anything else. Now we're gonna do the third time out. Patient's name, what they're having done, any allergies, any special concerns, that is the time for everybody to speak up if there's any special concerns. If the patient told me something that they forgot to tell the surgeon, that is when I'm going to speak up and say, oh, actually, you know, the patient told me XYZ, Dr. So-and-so. The patient told me that afterwards they wanted their stent, you know, if you're going in to take out the stent. Whatever the patient told me, that's the time I'm going to speak up, okay? My antibiotic has to be all in by then because the surgeon is ready to go at that point. And they go, okay? He or she starts the procedure. I'm doing my charting at the facility that I work in. It's all computer charting, so all the numbers roll over. I had a very difficult time learning computer charting. I'm not even going to lie. I am used to paper charting, and I love paper charting. And everybody kept telling me, oh, you're going to love computer charting. I hated computer charting for a very long time. It's fine for me now. Still not a huge fan, but it is what it is. So at that point, you know, now I've also turned the bear hugger on. A bear hugger is a device that you use on the patients to keep them warm. Operating rooms are usually kept less than desirably cold for infection purposes and for staff purposes. Most of the staff gets hot running around. I am not one of them. If you've been following me for a while, you know I wear layers upon layers upon layers. I come in with layers and I add more layers when I get there because I don't like to be cold. So case has started, charting is started. Now I'm going to be looking at what I'm doing next. And if it's a cysto room, then I already know, right? So I already know kind of how the day is going to go. We are still not drawing up meds for our next one until that current patient is out of the room. And we're monitoring the patient, their heart rate, their blood pressure, if they're moving. Moving is usually moving usually indicates one of two things. Either they're not deep enough anesthetically or they may be having a little bit of pain. This is all subconscious. They're not awake. So I would give them some more pain medicine. Yeah, you've seen that wink. Because I'm not going to say y'all are picking up what I'm throwing down. But moving indicates, you know, deep in the anesthetic, maybe they're having some pain. If it's a cystal case, it might be a reflex. The doctor might be in there doing something and it's a reflex and all of a sudden, you know, the leg kicks. So I would ask, did you just hit something? And they might say, oh yeah, you know, that was just a reflex. Because I'm like, okay, because, you know, I'm at 1 Mac and like they're not breathing yet. So I just want to make sure. So then maybe it's around like 8:30 by now, 8:15, somebody may come in and say, hey, do you want your morning break? Usually morning breaks start around 8 o'clock. Whoever the break person is will just go around. They'll look at the board, they'll see who needs a break, and they'll just start doing breaks. When you get offered a break, take a break. Because you do not know when and if you will be offered a break again. That break person could get pulled somewhere else, or emergency could happen and then that break person is no longer free. So when you get offered a break, take your break. Okay. Let's see, what else? So after my break, usually I go and hydrate. I use the bathroom. I may make any phone calls that I need to make or respond to any text messages I need to respond to. And then by the time I come back, you know, they may be done. So that break person may have woken that patient up for me. And, you know, they'll say, oh, the patient did great. You know, they may have an oral area in. I don't know. Like, the break person took over the anesthetic. So they woke the patient up for me. I'll give you a different scenario if I wake a patient up. But let's say they woke the patient up for me. So now we're getting the patient over to their stretcher. Since the patient still is very sleepy under general anesthesia that they just had, we're going to physically have to move them. 1, 2, 3, count, and move. You all need to move as one unit. You are the counter as the person at the head of the bed. As a CRNA, as the anesthesia provider, you do the counting. 1, 2, 3, move. Nobody moves without your count, okay? So if somebody else tries to take over your count, this is how you do it. Somebody else trying to take over your count and say, okay, we're ready. 1, I'm not ready yet. And that's not a control move. That's you reorienting to, hey, airway first. Okay, so if the airway is not ready to move yet, we're not moving. Okay, so we move over to the stretcher, and then we make sure all of our charting is good. We make sure, the patient is breathing. Obviously, we wouldn't have pulled the LMA if they weren't. They might be moving a little bit, so we know we're good, right? We can disconnect our monitors, and now we're going to go to recovery. We're going to hook them up to the monitors and PACU. We're going to give report to the PACU nurse. We're going to do our final vital signs, and then we're going to go and we're going to get set up for the next case. Usually the staff is, cleaning up, and they're taking out the trash, and they're, it's called turnover. That is what turnover is called. So if you ever hear that word, turnover, we want a fast turnover, or your turnover took too long. That is what they're referring to. How quickly the room turns over, how quickly the room gets clean, and you're ready for the next patient, okay? There are different facilities that want turnover to be a certain amount of time, like less than 20 minutes. That is a quick turnover. Less than 20 minutes is fast. I've worked at, when I did cataract surgeries, eye surgeries, our turnovers were 3 minutes. Bring the patient out, wash your hands, go get the next patient, come in. Those were quick surgeries. So quick turnover, quick amount of cases, that's what that means. So turnover time, that's when I go and draw up my meds for my next patient. And then I'm looking on the computer again. So basically everything that I did initially, I'm now doing again for my second patient. Okay, so I'm looking up the next patient. I'm getting their meds ready. I don't have to check the machine again because I've already done that in the morning. The anesthesia techs are wonderful where I work. They come, they clean off everything for me. Okay, I think I'm seeing things. I'm seeing things and I'm hearing things. I don't know what's going on today. So the anesthesia techs, they come, they clean off everything for me. They wipe everything down. They get my EKG and blood pressure cuff and all of that wiped down for me. Sometimes they're short-staffed though, so I know how to turn over my own room. I learned that very quickly. Like, you need to know how to also turn over your own room because sometimes there's only one anesthesia tech, or they're off helping with a code, or they're off-site helping do something else. So you need to also know how to do your own stuff, okay? So I may wipe down my own stuff if the anesthesia techs are busy doing something else. And then I ask the circulating nurse, you ready? He or she says, let's do it. And then we go and we see the second patient in pre-op. So usually this is around 9 or so. So that's kind of how the mornings go. I'll give you another scenario. So we've done the same thing. We're going to do the same thing with the second patient. We're going to meet them. Hey, I'm Crystal. I'm your CRNA. I'm going to be taking good care of you today. What are you having done? Blah, blah, blah. I saw that you're concerned about XYZ. You get post-op nausea and vomiting usually. Okay, so we're going to put a scopolamine patch behind your neck. So that's how you build rapport. Very quickly, very fast. And then, boom, first said, going to the next room, to the operating room with this next patient. So I want to take you through the steps of waking a patient up. So we put the patient to sleep the same way that we did our first case. We gave them oxygen, we put the monitors on them, gave them medications, put them on the ventilator, did our timeout, surgeon started. Let's say the surgery is over now. So now this is called emergence. So there's 3 phases of anesthesia. There's induction, there's maintenance, and emergence. So now we're on emergence. Surgeon, 5 minutes, he or she may say 5-minute warning, or, I'm almost done. Some of them are truly almost done. Others say they're almost done, and then they need a little more time. So you'll learn as you learn your surgeons. So now we're on emergence. So I'm gonna, start cutting off my gas, start backing down on my gas, depending on how long he or she says they have. The patient is already breathing. I've made sure that they're already breathing on their own, and then I'm gonna do something called turning up my flows. And depending on the patient, I may either do a deep emergence or I may do an awake emergence. It all depends. Again, these are all things you'll learn in CRNA school. with different preceptors, or even once you start working on your own as a CRNA. So I just want to throw those terms out so that when you are in that role, you'll know, oh yeah, I remember hearing something like, deep emergence or wake. So I'm going to turn up my flows. I'm going to make sure my patient's breathing. They may respond to some stimuli if I'm doing a wake. If I'm doing a deep, they're not going to really respond, but I'm going to have different techniques that I'm about to use in order to assist them as I do a deep emergence. And then we're going to pull the LMA out and put a face mask on them, with some extra oxygen. If their breathing is not the way I want them to breathe, I'm going to do some different techniques to make sure that I have them breathing a certain way. And again, you'll learn all of those tips and pointers and tricks in CRNA school. And bring them over to the bed. Remember, anesthesia has a count. On my count, 1, 2, 3, move over to the stretcher and make sure all your vitals are good. Make sure the patient's, airway is patent by then, and bring them to PACU. You give your report to your PACU nurse. You hook them up to the monitors. You do your final vitals, and then you do it all again. So in the beginning of this video, I said we were going to have 7 cases, right? So literally, you're going to be doing that 7 times, unless you're leaving at 3 o'clock, which they may not be done with by then. But don't sleep on some of these surgeons. They are quick. Turnover is quick. And you can do all 7 of those cases, maybe even by 1 o'clock, and be done. I would get a break for lunch. Somebody would come in, they would give me a break, 30 minutes for lunch. I do like 32 minutes. I'd set a timer on my phone, and I carry my lunch with me. I don't go to the cafeteria because I need all my time. Okay, so I need all my time. I like to sit and I like to have my lunch. So I put 32 minutes on my stop clock on my phone, and I go eat. After lunch, you come back to your room, and whatever part of the case they're in, remember, so we just talked about induction, maintenance, and emergence. So whatever part of that they're in, when I come back from lunch, I step in, and the CRNA or the doc who gave me lunch, they're going to tell me what they did, if anything, or they're going to say, I didn't touch anything. I left your anesthetic, the way that you had it. And I say, okay, thanks. And then they're going to leave, and then I'm going to take over. So you just keep doing that until your shift is over, essentially. Whether you're working 8 hours, whether you're working 10s, 12s, 16s, or you're on call. I don't do call. I have no desire to do call. I don't do 24-hour shifts. I don't do nights. The most that I have done is 12 hours, and that was enough for me. In CRNA school, I did do 16 hours. I'm not interested. Give me 8 hours. Let me go home at 3 o'clock. That's what I do. So that is a typical day. I did see a question earlier. Do CRNAs typically specialize, or is it common to work multiple specialties? Nope, you can specialize. So at this facility, we do have OB CRNAs. They strictly they do OB. When the pandemic hit, there was a lot of things that got moved around, we know, during the pandemic, right? ICUs got opened, and different people had to go work in ICUs and things like that. So when the pandemic hit and kind of a shortage occurred of nurses and CRNAs and PRN staff and things like that, the OB CRNAs did come to the main operating room to help with anesthetics. You can specialize in OB. There's cardiac CRNAs. There's CRNAs who straight up cardiac. That's all they want to do is cardiac. There's pediatric CRNAs. All they want to do is peds. I don't do I am not interested in doing peds. I have occasionally done pediatric cases, but pediatrics is not something that I love to do. There are CRNAs who love to do peds. When I see them on the schedule, I say, hey, would you like to trade rooms? Because they love to do peds. I'm not the one. I also don't love OB necessarily. I know in school, tons of my classmates, they loved OB. One of my very good friends, all she does is OB. She does like 2 shifts. What does she do? Like 2 shifts, 2 24s every 2 weeks or something like that. because she's a mom and she wants to be home for her kids, so she'll go in, she'll do a 24 OB shift, she'll have a day off, and then she'll do another 24 OB shift, and then she's good for 2 weeks. God bless them. I'm not the OB person, and I'm not the 24-hour person. So yes, there's multiple shift options. There's multiple specialty options. You can pretty much pick. Okay, I loved cardiac in school. I haven't really focused on cardiac since I've been out of school. But if you love cardiac and you work at a facility that has a cardiac program and CRNAs do cardiac there, then you can be a cardiac CRNA. It all depends. What is another specialty? So we did OB peds. I would say neuro's a specialty, but if I've never really heard of just straight up neuro CRNAs. There might be. I'm not saying there's not. I have done some neuro cases, especially when I go to a larger facility to help. But neuro is, you either love neuro or you hate neuro. I think it's the same as neuro ICU. You either love it or hate it. So I have done some of that too. But yeah, those are pretty much the specialties. And like I said, I like bread and butter, 8-hour shifts. That's my gig, or 4 hours. Sometimes I'll go in and I'll help with morning breaks all the way up through lunches. So I'll come in from like 9 a.m. to 1. I love that shift because I get to do my things that I need to do in the morning and without having to wake up at 4 a.m. And then I know at 1 p.m. like everybody's taken care of, and then I still have the rest of my day. So I do a 9 to 1 shift. There's also like 9A to 9P shifts. There's 11A to 11P shifts. There are, what else have I seen? I've seen like 7 to 5. I used to do 7 to 5 for a while. I wasn't a fan of 7 to 5 or 7 to 5:30. There's also 7 to 7 a.m. to p.m. and then there's 7 p.m. to 7 a.m. I'm not a lover of night shifts. I did night shifts for many, many years as an ICU nurse. I'm not interested in doing nights. You don't want me at 3 a.m. doing. So I don't do nights. There's some that love nights. They love nights. I'm not the one. So, I hope this answered the question. I know I was on here much longer than I needed to be, but I just wanted to walk you guys through a typical day of a CRNA, of me as a CRNA. There might be other CRNAs whose days are totally different, whose shifts are totally different, and that's the joy of the career, because there is so much to choose from. I wanted to do this shameless plug. Of course, if you want to coach with me, you can email me. You can subscribe to my email list, thecrystalgrant.com. I have an 8-week session that's coming up in January that I'm going to be restarting. Or you can DM me and say that you're interested, and we can get on a Zoom call and we can talk. And I'd love to meet you, even if not, just for 15 minutes and find out what's going on with you and how I can help you. So you're very welcome. I'm glad this was informative. And make sure you go back and check out my other videos that I've done. Like I said, I've been going live every morning. I know Instagram's not telling everyone. So save this, share it with a friend, share it to your stories, whatever you want to do. But let's get the word about CRNAs out there and what we do. And yeah, I hope this was helpful, and I will see y'all later.